Bismillah ar-Rahman ar-Rahim. We talk in those lectures about imaging of pulmonary embolism. Pulmonary embolism imaging. Pathology, we talk about pathology of pulmonary embolism, imaging of pulmonary embolism, different modalities, pitfalls in diagnosis of pulmonary embolism with helical CT, multi-detector CT angiography, non-thrombotic pulmonary embolism, and other modalities. This image demonstrates angiography branches of pulmonary artery. The main pulmonary artery, this right mean lobar, left mean lobar, right mean lobar divided into right upper, right lower lobar, left mean lobar divided into left upper, left lower lobar. This is axial CT contrast image demonstrating main pulmonary artery, left pulmonary artery, right pulmonary artery. This is ascending aorta, superior vena cava, descending aorta, left main bronchus. Then also segmental pulmonary vessels. As we see, this is right ventricles, which anterior lying on the sternum, posterior left atrium lying posteriorly related to spine, right side right atrium, left side left ventricle will appear down. As we see, this segmental pulmonary vessels, and this is intercostal muscles. We see, and this is axial mediastinal window and CT. This is left pulmonary artery. This is right mean bronchus, right bronchus. This is left mean bronchus, descending aorta, superior vena cava. This is left pulmonary artery. In this level, we see this pulmonary artery divided into this right pulmonary artery, right mean lobar pulmonary artery. This we see left pulmonary artery, left mean lobar pulmonary artery. And we see down positions and segmentations of the pulmonary artery. Multi-detector CT show anterior segmental artery of right upper lobe. This anterior segmental artery, right upper lobe, right upper lobe segmental artery. And with this image, with this slide, we see medial segmental artery of right middle lobe. Medial segmental artery of right middle lobe and right lower lobe artery. Right lower lobe artery. This is segmental, medial segmental artery of right middle lobe. This we see left lower lobe pulmonary artery. Left lower lobe pulmonary artery. This is we see main pulmonary artery divided into left and right, and everyone divided into right upper, right lower, left upper, left lower. This is, as we see, branches of left upper, left lower, and so this is left lower, left upper. This branches is axial CT of pulmonary artery segment. This cross-sectional image of central vessels. We see right upper lobe segmental vessels, right upper lobe segmental vessels, right upper lobe segmental vessels, and this image right lower lobe segmental vessels, right lower lobe segmental vessels. This is left upper lobe segmental vessels, left upper lobe segmental vessels. Left upper lobe segmental vessels. This is upper divisions of left upper lobe. This left lower lobe segmental vessels. These definitions: left lower lobe segmental vessels. Definition of left lower lobe. Left lower lobe segmental vessels again. This is definitions: left lower lobe segmental vessels. This airway accompanied with airway branches of trachea. Pathology of pulmonary embolism. As we see in summary mechanism of pulmonary embolism, small embolus lodged in peripheral pulmonary artery give us pulmonary infarcts. Small artery lodged in the peripheral pulmonary artery give us pulmonary infarct. This is left pulmonary artery divided into left upper and left lower, and the left upper divided into segmental upper lobe and lingula. Multiple repeated emboli, as we see in small branches, that give us pulmonary hypertension. Massive coiled embolus in main pulmonary artery give us sudden death. This is very important pathology. Massive pulmonary artery in main pulmonary artery gives sudden death. Small embolus lodged in peripheral pulmonary artery give us pulmonary infarct. Multiple repeated small emboli showers give us pulmonary hypertensions. This pathogenesis of pulmonary thromboembolism. Pathological findings of pulmonary thromboembolism are often considered in two categories: those in which embolic episode acute, those in which embolic episodes are chronic or repeated. Pulmonary embolism may be acute or chronic. Pathological finding in acute pulmonary thromboembolism considered acute if they are partially or completely occluded arterial lumen and the arterial diameter was not reduced. In most instances, lung parenchyma, distal pulmonary embolism, either normal or slowly, only mild atelectasis and minimal intra-alveolar hemorrhage or edema. Chronic thrombopulmonary embolism considered chronic if at least two following features are present: eccentric location contiguous to the vessel wall, evidence of recanalization with an intraluminal filling defect, circumferential filling defect with central or eccentric patent lumen, arterial stenosis or weeps. At least two of the following features must be present to say chronic pulmonary embolism: reduction of more than 50% of the arterial diameter, complete occlusion at the level of the stenosed arteries, This is 5 criteria. 2 of them must be present to say chronic thromboembolism. Pulmonary embolism, either thrombotic, bland blood component, or non-thrombotic. Imaging for pulmonary embolism: chest radiograph, ventilation perfusion scintigraphy, pulmonary angiography, computed CT, either spiral or multi-detector, MRI, echocardiography, and transthoracic ultrasound imaging study to search for thrombosis, DVT, causes of pulmonary embolism, like duplex ultrasound of the lower limb. Embolism either with infarction or without infarction. Without infarction, most pulmonary embolism, 90% without infarction. Frequently, normal chest X-ray, pleural effusion may present with Stenmark sign, Knuckles sign, abrupt tapering of an occluded vessel distally, or elevated hemidiaphragm. Embolism with infarction present with consolidation, cavitation, pleural effusion, bloody in 65%, no air bronchogram, melting sign of healing, heals with linear scar like this, melting sign of healing, linear scars. Plain film radiography, chest X-ray, initial chest X-ray always normal. This is in pulmonary embolism. What signs in chest X-ray present? Hampton's hump consists of pleural-based shallow egg-shaped consolidation in the lung periphery with the base against the pleural surface. Pleural triangular shape, wedge shape consolidation, pleural based, base in pleura with the base, Hampton's hump. Another signs present in X-ray: watermark sign. Chest radiograph demonstrates pulmonary oligemia in the right mid-lung secondary to central right pulmonary embolus. Right, this is watermark sign, oligemia in the mid-lung, right mid-lung secondary to right pulmonary embolus. As we see, chest radiograph showing calcified pulmonary embolism. Radiographic sign, Hampton's hump, and watermark sign. Hampton's hump, pleural based, widget, consolidation shadows present based in pleura. Watermark sign, as we see, linear marking present. Watermark sign present نتيجة small as a result of a small embolus in the middle segmental vessels. Linear marking. Chest radiograph show pulmonary infarct in the right lower lobe. Pulmonary infarct in the right lower lobe, wedge-shaped consolidations, chronic pulmonary infarctions. First imaging modality, we talk about ventilation perfusion scanning. What we do, what is the mechanism, what is idea of ventilation pulmonary scanning? Idea depends on we inject radioactive compound by two way, inhalation way and intravenous way. Radioactive compound inhaled into air space of the lung. In a normal lung, this will distribute evenly to all regions. Radioactive compound into vein travels in the lung tissue on the blood vessels. So area devoid of blood vasculature as a result of embolism, like here, radioactive compound don't go through this area of the lung. But in this way, inhaled way, it passes through tracheal main airway, which is patent in the pulmonary embolism. So radioactive material goes through all lung part. Here, radioactive material in intravenous way, devoid areas deprived by blood supply as a result of pulmonary embolism. Pulmonary embolus is a blood clot in the pulmonary artery. No injected material reaches these regions because of pulmonary embolism. We do mismatch between image with radioactive material injected intravenous and the image with radioactive material inhaled. So mismatch of inhaled and injected compound in the lung is equal pulmonary embolus. Ventilation perfusion study. Ventilation may means inhaled radioactive material. Perfusion means intravenous material. Ventilation perfusion scan result. This is perfusion way, this is ventilation way. We do mismatch between both and we talk about possibilities and the grading of pulmonary embolism. Advantage of ventilation perfusion study. Arteries from lingula remain the most difficult to interpret by spiral CT due to their small caliber. Unlike spiral CT, it has no absolute contraindication. So, ventilation perfusion study, you can detect areas supplied by arteries from the lingula. Drawbacks of ventilation perfusion study. Non-conclusive result of intermediate probability category of the test. Inter-observer variability. False negative lung scan interpretation tend to have non-occlusive subsegmental thrombi. Other causes of ventilation perfusion mismatch in the absence of pulmonary embolism. False positive ventilation perfusion study include who don't have acute pulmonary embolism is related to chronic or unresolved pulmonary embolism. The compression of pulmonary vasculature by mass lesion adenopathy mediastinal fibrosis. Pulmonary vasculature occluded but not by embolism, by compression from outside. The vessel wall abnormality, pulmonary artery tumors and vasculitis give us false positive ventilation perfusion study. Non-thromboembolic intraluminal obstruction like tumor emboli, foreign body emboli. As we see, ventilation perfusion study cannot differentiate between causes of pulmonary embolism, thrombotic or non-thrombotic. Lastly, congenital vascular abnormalities like pulmonary artery agenesis or hypoplasia, give us false positive filtration perfusion study, but spiral CT, helical CT, multi-detector CT can detect these abnormalities. Spiral multi-detector CT, this is aim of our study. CT contraindicated in cases of renal failure disease, sensitive for pulmonary embolism in proximal pulmonary artery but less so in the distal segment. This CT. CT quickly becoming test of choice, gold standard for initial evaluation of suspected pulmonary embolism. CT detect extraluminal non-vascular abnormality which may cause compression of pulmonary vessels. CT also detected non-thrombotic pulmonary embolism like tumor embolism. CT also detect pulmonary artery abnormalities like pulmonary artery agenesis. The advantage of CT. Pulmonary embolism diagnosis in chest CT. Accurate for segmental or larger pulmonary embolism. Sensitivity 85 to 95%, specificity 90 to 100. Accuracy depends on interpreter. Large interpreter variability reduces accuracy with less experience. Can identify other pulmonary etiologies. The diagnostic performance of CT angiography for detecting subsegmental thrombi is lower. Diagnostic performance for CT angiography for detecting subsegmental thrombi is lower. Technique improve high volume of contrast 100 to 150 millibolus, 3 to 4 milli per second, 15 to 17 seconds scan delay, 2 to 5 millimeter thickness. CT features of pulmonary embolism. The cardinal sign, this is our home message for pulmonary embolism in CT pulmonary angiography, is intravascular filling defect in a pulmonary artery that partially or completely occluded the vessel and is often associated with increased diameter of the affected vessels. What is helical CT finding of acute pulmonary embolism? This is target of our lectures. Acute pulmonary embolism finding in CT. Vascular abnormality include: first, intraluminal filling defects, acute angles with the vessel wall, total cut off vascular enhancement, enlargement of unoccluded vessels. 4 sign: intraluminal filling defects, acute angles with the vessel wall, total cut off vascular enhancement, enlargement of unoccluded vessels. Okay, this direct sign which we see in acute pulmonary embolism. What is ancillary finding pulmonary embolism? Ancillary signs non-specific by themselves can be helpful in case of subtle thrombus. Ancillary findings suggest acute pulmonary embolism. Pleural paced wedge shape areas of increased attenuation with no contrast enhancement, linear atelectasis, expanded and opacified vessel, eccentric filling defects, peripheral wedge shape consolidation, oligemia, peripheral effusion. Peripheral effusion. This is ancillary finding of acute pulmonary embolism. What is CT finding on chronic pulmonary embolism? Cardiac abnormalities, right ventricular enlargement, right atrial enlargement, thrombi in right atrium or ventricle. Vascular abnormalities in a chronic pulmonary embolism, eccentric filling defect at angle with vessel wall, irregular or nodular arterial wall, abrupt narrowing of the vessel diameter, abrupt cut off distal lobar or segmental artery, recanalization of the thrombosed vessel, weeps or bands, less frequent. Pulmonary abnormalities in chronic pulmonary embolism, bronchial artery dilatation, bronchiectasis, areas of decreased attenuation in the lung, mosaic perfusion. Chronic pulmonary embolism, CT finding either cardiac abnormalities, vascular abnormalities, pulmonary abnormalities. Now we start. This is right pulmonary artery as we see. This is interlobar artery as we see. This is right pulmonary artery with black arrowhead. This interlobar pulmonary artery. We see filling defect, area of low attenuations, non-enhanced feeling defect, and this is extensive pulmonary embolism. As we see, the anterior segment of right upper lobe pulmonary artery, right upper lobe pulmonary artery, areas of feeling defect, centralized, not make angle with the wall. This is pulmonary embolism. Left pulmonary artery here, this left pulmonary artery is extensive pulmonary embolism. Acute pulmonary embolism in longitudinal sections, railroad track sign. As we see pulmonary embolus, it is longitudinal axis with the fissile directions, railroad track sign. This characteristics signs as we see. Next we see what we see. This is main pulmonary artery, this left and right and left pulmonary artery. We see bilateral areas of feeling defect, cut off or contrast enhancement, areas of low attenuations, non-enhancement. This is pulmonary embolism. Extensive intraluminal feeling defects in both pulmonary arteries. We see here left segmental pulmonary artery, right lower lobe segmental pulmonary arteries, thrombus extending segmental and subsegmental branches. We see areas of feeling defect, low attenuation, non-enhanced, intraluminal feeling defect. This is pulmonary embolism. Next image, as we see, this is areas of what? This is right lower lobe pulmonary artery, lobar pulmonary artery, right lower lobe pulmonary artery, areas of feeling defect, intraluminal. This left lower lobe segmental vessels. This is acute pulmonary embolism. Abrupt cut off contrast enhancement, centralized, not make angle of the wall like coronary pulmonary embolism. No areas of recanalization like coronary pulmonary embolism. Intraluminal feeling defects. This is left lower lobe segmental vessels, acute pulmonary embolism. As we see in these images, yes, this is lung window. We see wedge-shaped areas, pleural based in the left right lower lobe. Pulmonary infarct. This area non-enhanced with contrast, no blood, devoid of blood supply. This pulmonary infarcts. As we see here, right descending pulmonary artery, right descending pulmonary artery. What mean right descending? This is right descending pulmonary artery, and this is left descending pulmonary artery. Calcification is a left pulmonary artery compatible with calcified thrombus. Calcification in the left pulmonary artery compatible with calcified thrombus. Here, right descending pulmonary artery. Right descending pulmonary artery, intraluminal feeling defect. Here, see calcified pulmonary artery left thrombus, compatible with calcified thrombus. Chronic pulmonary embolism with recanalization of thrombus. This is, we see areas of low attenuation. This is pulmonary embolus, left right descending pulmonary artery. Here we see contrast. This is start of recanalization, compatible with chronic pulmonary embolism. Excellent degree of vascular enhancement, multi-detector, 80 milli contrast bolus triggering mechanism. This is the how example of excellent degree of vascular enhancement, sufficient amount of contrast injected by bolus triggering methods. Acute pulmonary embolism, partial feeling defect in the anterior segmental artery of right upper lobe, anterior segmental artery of right upper lobe. As we see this area, this is partial feeling defect, anterior segmental artery of right upper lobe, segmental pulmonary embolism. Medial segmental artery of right middle lobe, medial segmental artery of right middle lobe, partial feeling defect in the right lower lobe artery, partial feeling defect in the right lower lobe arteries, acute pulmonary embolism, centralized. This is area of embolism, this area of embolism. Right, left lower lobe pulmonary artery. We see this. Don't miss acute pulmonary embolism. Don't miss. Don't wait to see embolus clear large in the main pulmonary artery. Try to find it in segmental artery. Left lower lobe pulmonary artery. Acute pulmonary embolism. Isolated feeling defect in a subsegmental pulmonary artery of external segment, as we see, of the right middle lobe. External segment of right middle lobe. This is isolated feeling defects. This is pulmonary embolism. This is infarct area corresponding to this pulmonary embolism with G-shaped pleural base, triangular, no enhancement. This is pulmonary infarct. Massive acute, subacute, chronic pulmonary embolism. As we see, main pulmonary, as we see, right upper, left upper pulmonary vessels, we see multiple area of feeling defect. Here, left main pulmonary artery, see area of pulmonary feeling defect, intraluminal feeling defect, large, as we see, centralized. Here in the right side also we see right lower lobe pulmonary artery. This is segmental, this segmental bilateral lower lobe vessels. This is acute, subacute, chronic pulmonary embolism, massive pulmonary embolism. Here we see all degree, acute, subacute, and chronic. Right lower lobe segmental feeling defect, as we see, with irregular edges. Right lower lobe segmental feeling defect. Left upper lobe posterior segmental defect. Left upper lobe occupying left upper lobe posterior segmental defect, occupying about 70% of the artery. Left upper lobe posterior segmental defect. As we see, left main pulmonary artery, intraluminal feeling defect, pulmonary embolism. Left main pulmonary artery. Left upper and lower lobe, left upper and left lower lobe pulmonary arteries, another feeling defect as seen in the right interlobar pulmonary artery. Right interlobar pulmonary artery is massive pulmonary embolism. Segmental branch of left lower lobe, as we see, intraluminal feeling defect. Right lower lobe segmental artery feeling defects. Compatible with pulmonary embolism. Right and left lower lobe pulmonary artery. Right and left, this left, right and left lower lobe pulmonary artery. Bifurcation of the left lower lobe pulmonary artery. Left lower lobe pulmonary artery bifurcation, intraluminal feeling defects compatible with pulmonary embolism. This is both right and left main pulmonary artery. Right and left main pulmonary artery. Right upper lobe pulmonary artery, thrombus seen in the left lower lobe pulmonary artery also. Bilateral extensive pulmonary embolism. Left lower and right middle and left lower lobe pulmonary vessels. This is right middle, this is left lower and right middle and lower lobe pulmonary arteries. This is extensive pulmonary embolism. Multiple bilateral pulmonary embolism. Right main pulmonary artery, intraluminal feeling defect. Right lower lobe pulmonary artery, intraluminal feeling defect. Right and left lower lobe pulmonary artery, right lower lobe pulmonary artery, left lower lobe pulmonary arteries, intraluminal feeling defect. Multiple bilateral pulmonary embolisms. Pulmonary embolism, an embolus seen in the right lower lobe pulmonary artery, intraluminal feeling defect near gust distal to its origin from the right interlobar pulmonary artery. This is pulmonary embolism. Pulmonary embolus in the right upper lobe pulmonary artery. Right upper lobe pulmonary artery. This is pulmonary embolism, intraluminal feeling defect. We see cardinal sign, it is intraluminal feeling defect, cut off contrast enhancement. Right lower lobe pulmonary artery, intraluminal feeling defect, as we see. Bilateral pleural effusion present. This is the pulmonary embolism. Pitfalls in diagnosis of pulmonary embolism with helical CT angiography. Not all news good. Sometimes you have bad news. Sometimes we have mistake and give false positive of intraluminal feeling defect. We give bad impression or wrong impression that is pulmonary embolism, and this is not true. What causes of misdiagnosis of pulmonary embolism? Patient-related factors, respiratory motion artifact, image noise, pulmonary artery catheter, flow-related artifact, technical factors like window sitting, streak artifact, lung algorithm artifact, partial volume artifact, stair step artifact. All this give us fallacies of intraluminal feeling defect of pulmonary vasculatures. Anatomic factors which give us pitfalls, partial volume affecting effect in lymph nodes, vascular bifurcation. These anatomic factors: partial volume effect, lymph nodes, vascular bifurcation. Pathologic factors which give us pitfalls during examination for pulmonary embolism. Pathologic factor like mucus plug give us false positive impression that is intraluminal feeling defect of pulmonary embolism and the perivascular edema. Pitfalls of CT angiography: simulation of thrombosis by various structures like pulmonary veins, bronchi, lymph nodes, pulmonary arterial catheters, vascular shunts. Technical limitation: improper bolus timing, streak artifact, motion artifact. Pseudo feeling defect which present intraluminal in the pulmonary vessels which give us false positive impression. Technique related pitfalls include inadequate selection of injection parameters such as flow rate, concentration, scan delay, improper selection of the duration of the apnea. So you must know that is proper technique give us good result and less limited fallacies. Proper technique by mean adequate selection of injection parameter like flow rate must be adequate, concentration of contrast amount adequate, scan delay time, and proper selection of duration of the apnea. As we see, 40-year-old woman with pulmonary embolism at the level of left upper loop, areas of intraluminal feeling defect, parallelism and the proximity of the arteries and the pulmonary and the bronchi. As we see, parallelism and the proximity of arteries and bronchi. Conversely to veins, as we see, note that pulmonary embolism is at level of subsegmental artery at apicoposterior segment. This is levels at apicoposterior segment. This is parallelism and the C of thoracic airway, artery and veins. Posterior and the medial location of venous return of apical segment of inferior lobe. Posterior and medial location of the venous return at the apical segment of the inferior lobe. This normal anatomy. Confluence of vessels into inferior pulmonary vein. This is normal anatomy as we see. 60-year right inferior segmental artery. Pseudo feeling defect within pulmonary vein. Pseudo feeling defect within pulmonary vein. Intravascular area of low attenuation in the pulmonary vein. Medial topography of the vessel wall thin. Note respiratory artifact. Here disappear. This is present as a result of respiratory artifact, pseudo feeling defect within pulmonary vein. Columnar artery within anterior segmental artery at the same level. This anterior segmental artery, this columnar artery. The variant anatomy of lingual artery is a fallacies 60-year. Lingular artery originating from columnar artery instead of left interlobar parallelism with lingular bronchus is well seen. Left lobar parallelism with lingual bronchus seen here. Hilar lymph nodes and the perivascular tissue. 45-year-old woman with normal right hilar lymph node located between intermediate bronchus and right interlobar. Intermediate bronchus and right interlobar. This area This is simulate mural thrombus, give us false positive diagnosis of right interlobar pulmonary embolism. It's not true. As we see, enlarged lymph nodes medial relation to the left interlobar pulmonary artery with nodular shape, 60. Enlarged pulmonary lymph nodes as left hilum. Perivascular nature of hypodensity tissue. This is then a false positive impression of pulmonary embolism. As we see, partially calcified lymph node making filling defect, partially calcified lymph nodes, intersegmental lymph node mimicking pulmonary embolism. Calcified lymph node will differentiated from contrast enhancement pulmonary artery. This is calcified lymph node. Give us bad impression, that is pulmonary embolism. A large lymph node at columnar level, hypodense lateral to columnar artery. This could correspond to lymph node or marginal clot. As we see, perivascular nature of hypodensities between artery and bronchus. Perivascular nature of hypodensitis. 60-year-old male, unilateral lymphangitis carcinomatosa. Areas of low attenuations, stimulating pulmonary embolism. Visualization of vessel in transverse section, as we see in curved arrow, confirm perivascular topography of the hypodense not associated pleural effusion. This is lymphangitis carcinomatosa. Pitfalls related to vessel orientation. Area of low attenuation projecting on anterior segmental artery upper loop. Anterior segmental artery of left upper loop. As we see, anterior segmental artery of left upper loop. We back again. Anterior segmental artery of left upper loop. We search of it. This is we see related to orientations. Area of low attenuation and the anterior segmental artery of left upper loop because of partial volume defect from lung parenchyma. This will seen in B. This is pitfalls related to vessel orientation. 70-year-old male, tortuosity of right pulmonary artery simulating endoluminal abnormality. Hypodensities are related to vessel wall. This is Dina pitfalls. Kinetic artifact, pseudo-feeling defect caused by motion artifact. As we see, pseudo-feeling defect of posterior segmental artery of right lower lobe. Posterior segmental artery is motion artifact. On only one axial image, respiratory motion artifact better shown in P, as we see here. Complete opacification of the vessels without any motion artifact. This is give us false positive diagnosis, pseudo-feeling defect. Pseudo-feeling defect caused by cardiac and respiratory kinetic artifact generate intra-arterial hypodensity area simulating pulmonary embolism. This artifact will seen not pleural effusions, seen here. Streak artifact, 65-year-old male, flow-related artifact from superior vena cava. As we see, generated hypo and hyper attenuated radiating images over right main and the upper lobar pulmonary arteries. Streak artifact. As we see, small area of low attenuation in the interlobar pulmonary artery partially obscured by dense surrounding contrast material. Intraluminal clot, underestimated pulmonary embolism obscured by dense surrounding contrast material. Here, underestimating, false negative diagnosis of pulmonary embolism. False negative diagnosis of pulmonary embolism. Insufficient enhancement. This is one which gives us causes of false negative. Inadequate delay of injection, too long delayed enhancement of the pulmonary arteries can also be related to factors intrinsic to the patient, insufficient contrast. So this is we must do proper technique, insufficient enhancement. Non-thrombotic pulmonary embolism. We take before that pulmonary embolism either thrombotic or non-thrombotic. Non-thrombotic pulmonary embolism, septic pulmonary embolism, hydrated pulmonary embolism, fat embolism, amniotic fluid embolism, tumor embolism, air embolism, talc embolism. We see multiple cavity nodules throughout both lungs in this image. This is septic pulmonary embolism. 20-year-old male intravenous drug abuser, assuming immune deficiency viral infection. We see fading facial sign, facial leading directly to nodule in several nodules. This is septic pulmonary embolism. This is septic emboli, metastatic lung abscess, scattered thin-walled cavities throughout both lungs, associated with ill-defined areas of consolidation in peripheral portion of both lower lobe. We see here scattered nodules can be identified, both solid and in various stages of cavitations. Subpleural feeding vessel associated, as we see, with many of them, compatible with hematogenous seeding in a patient with documented tricuspid vegetations. Metastatic lung abscess. Pulmonary hydrated embolism caused by rupture of a mediastinal hydrated cyst into the right pulmonary artery. 20-year-old female. Pulmonary transplantation patient. Enlarged or engorged branch of pulmonary artery in the bilateral lower lung zones. Enlarged and engorged branches of pulmonary artery. This is bilateral ground glass areas of increased opacity. In fat embolism. And 58-year female intramuscular injection of some fatty material into the buttock several days earlier. We see widespread patch ground glass attenuations, consolidations. A follow-up radiograph after 10 days show complete resolution of ground glass pattern fat pulmonary embolism. Pulmonary tumor thrombotic microangiopathy caused metastatic gastric carcinoma in 57-year-old man. Left basal trunk show multifocal tree imped appearance caused by tumor emboli. This is talc embolism. 37-year-old male drug abusers. Left interlobar show diffuse pulmonary involvement. Left interlobar diffuse pulmonary involvement with ill-defined centrilobular small nodules, not also nodular branching structure, tree imped. Nodular branching structure, tree imped. This is cement embolism in 29-year-old female patient recently undergone embolization by cyanoacrylate intracerebral or EV malformations. Widespread small pulmonary nodules finding represent cement embolism. Here, embolism following percutaneous vertebroplasty, ball missile mesylcitrate, inferior portion of left pulmonary. Here we see firstly pelvic L2, tortuous paravertebral vein filled with polymethyl mesacrylate material. Vertebral body has been reinforced with this material, vertebroplasty. And this is material of vertebroplasty goes through these veins, paravertebral veins, and then to the lung. Inferior portion of left atrium shows regioblique emboli in the segmental subsegmental levels of pulmonary arteries. Other modalities to investigate pulmonary embolism. Pulmonary angiography. Angiography most definitive technique for diagnosis of pulmonary embolism. However, because angiography invasive technique seldom performed even in major academic centers. Pulmonary angiogram, we see areas of feeling defect, as we see here. Pulmonary embolism, pulmonary arteriogram, normal, lobar feeling defect, segmental feeling defect. We see also this is pulmonary angiogram, acute pulmonary embolism, and pulmonary angiogram. Right side left pulmonary artery, selective injection demonstrating multiple feeling defect and facial cut off sign of contrast enhancement. And this is also demonstrate chronic pulmonary embolism with stenosis of right pulmonary angiogram, segmental stenosis of the right upper lobe pulmonary artery. MR angiography with contrast is another modalities, as we see multiple feeling defects MR Real Time Angiography, multiple feeling defects as we see right side and left side. MRI angiogram, very good, visualize blood flow, almost similar to angiogram, 3D MRA. And this is MR acute pulmonary embolism, magnetic resonance, feeling defects as we see compatible with pulmonary embolism, and right and left main pulmonary artery. Same signs which we took in the CT, same signs, feeling defect, intraluminal, and so on. MRA, relatively high signal in the right pulmonary artery. Close up view, we see embolus in distal right pulmonary artery. Embolus distal right pulmonary artery. This embolus distal right pulmonary artery. Ultrasound also can be used. Scanning with compressions will aid to detect any thrombus. Highly sensitive and specific for diagnosis of DVT. Look for areas of low signals, DVT of the lower limb, would identify the cause, and use transthoracic ultrasound. And you see, look areas of low signal, intravascular defect, non-collapsing vessel, venous sign, compression technique, and so on, the sign of DVT. Dimer assay, gainfully employed select patient for further radiological imaging. It's cross-linked fibrin degradation product and the plasma marker of fibrin lysis. Serum level less than 500 exclude pulmonary embolism with 90 to 95 accuracy. Unfortunately, positive test non-specific. Specificity only 25-67% occurs in about 40 to 79% of patients. Unreliable in presence of, this is dimer assay, unreliable in presence of malignancy, sepsis, recent surgery, recent trauma. Malignant sepsis, recent surgery, recent trauma. Thank you very much. We talk in these lectures about pulmonary embolism. We hope to give us go home message about how to detect pulmonary embolism in CT, acute signs and chronic signs. Don't miss its emergency. And the diagnosis must be in table of pulmonary embolism. Thank you very much.